All right. Good morning, everyone. Welcome to this morning's citywide medical grand rounds with St. Joseph Healthcare Hamilton as the host site. Next slide, please. And we're super excited that everybody can join us today after summer hiatus. We've just been back for a few weeks. And we've got a whole excellent lineup of speakers and topics through this academic year. Next slide, please. As always, we will start with Indigenous land acknowledgement. We acknowledge that St. Joseph Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinabe, Mississaugas, and Haudenosaunee that bound them to share the territory and to protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. And I'll highlight that here we are in the month of September, and next week is the week of Truth and Reconciliation, culminating in the Day of Truth and Reconciliation, which becomes a time for us to really reflect and focus and perhaps even go to the Truth and Reconciliation document and review aspects that each one of us can learn from, both in our medical practice and in our lives. Next slide, please. So really delighted to have our first chief medical resident grand rounds here at St. Joe's for this academic year. We have Dr. Shamma, Boushahri, Daniel Lazzam, and Kelsey MacEachern, who will be presenting to us on the topic of semaglutide, where we are now and where we're going. And I'm going to hand things over. My co-host today is Dr. Amanda Huynh, who is our CTU director for St. Joe's CTU, and she's going to give a little bit more intro to our speakers.
Great, thank you. So I would like to introduce our CMRs. The chiefs play a very important role here on the CTU in terms of coordinating our educational sessions and then administrative work as well. Dr. Shamma Boushahri is an R3 who's interested in endocrinology. Dr. Daniel Lazzam is also a third-year resident who is interested in cardiology. And Dr. Kelsey MacEachern is a third-year resident who is interested in general internal medicine. So I'll pass the torch to you guys and get started.
Hello, everyone. I'm Shamma Boushahri. I'll be starting this talk. Thank you for being here. So we're going to be talking about semaglutide, where we are now and where we are going. Next. So we have no conflicts of interest to disclose today. Our objectives are to briefly review the GLP-1 pathway and give an oversight of what goes on behind the scenes when developing drugs, particularly GLP-1 agonists, understand what the current evidence-based indications are for GLP-1 agonist therapy, and talk about adverse effects and the future directions. And we also wanted to shed light on the role that fat phobia plays in medicine. Our case is Deborah, a 30-year-old lady who's 3 months postpartum and is being seen at her family doctor's office after a pregnancy that was complicated by gestational diabetes mellitus. She has some blood work that she's here to review today. Apart from the gestational diabetes mellitus that complicated her pregnancy, she has a past medical history notable for asthma. She has a family history of type 2 diabetes mellitus in her mother, and her father had an NSTEMI at the age of 42. Notably, on physical exam, she has a BMI of 34.8. Investigations reveal a fasting glucose of 6.3 and an A1C of 6.2%, consistent with a diagnosis of prediabetes. So looking at the GLP-1 pathway, what we understand is that it's a gastrointestinal peptide that's released from the small intestine after a meal. And the main effect that it has is to bind to the receptors that are in the pancreatic beta cells and stimulate the release of insulin in a glucose-dependent fashion. But in addition to that, we see that it has effects by delaying gastric emptying, inhibiting meal glucagon release in the setting of hyperglycemia, which is an inappropriate response, and reduced food intake. It's normally degraded by the DDP4 enzyme, and the half-life is relatively short, 1 to 2 minutes in the body. However, the synthetic agonists that are being made today are resistant to degradation given their synthetic nature and have longer half-lives, permitting us to use them as once daily or once weekly dosing.
Now that we've talked a little bit about the GLP-1 pathway, we also wanted to give a brief overview of the logistics behind the drug development process so we can understand how we got to the point where we're using semaglutide the way we are today. So a lot of drug development starts with basic research, molecular, biological, pathophysiology, focusing on, in this case, that GLP-1 pathway that we've covered. Then we move into the research and development perspective. So we've identified that GLP-1 might be a place that we could target with regards to medication, but we also need to find a way to synthesize that compound at scale and to then develop that as a drug. Then we move into the preclinical studies, which is testing in vitro, so in the lab, as well as in vivo in live organisms. And this is really to prove that the GLP-1 pathway would have the effects that we think it's going to have in terms of the drug that we're looking to design. We're all very familiar with the clinical studies, the phase 1, phase 2, and phase 3 studies. But even after drugs are approved by the FDA, they do go through a post-release monitoring phase. So we are monitoring for side effects, the long-term effects, and anything that really was not identified during the clinical studies. This is more of the logistical process in terms of drug development, but there's also some other factors that play a role. And one of the factors we wanted to talk about was the profit behind drug development. And so I want to draw your attention to this article that was recently published in the New York Times. And it's really looking at the fact that the Danish company that makes Ozempic, Novo Nordisk, is really changed the whole entire shape of the Danish economy due to how profitable Ozempic has been. And in some ways, this is really great because the Danish country has had a lower interest rate that's been good for the economy. There's been a lot of jobs that have come out of this. But in the same way, it's created a huge demand for the drug. And this has been further exacerbated by the fact that there's been a lot of marketing surrounding Ozempic. I think we've all seen commercials for Ozempic multiple times by this point. And so with that demand, it's created some shortages, and it's also created kind of a demand for drug companies to try to develop even more effective drugs along the same vein as Ozempic, as well as what we call knock-on products. So other weight loss kind of products that people might be using.
We would be kind of remiss if we mentioned this topic without going into some of the cultural and societal implications. Obviously, Ozempic's been very effective in causing weight loss, and with that has been a lot of kind of uptake of this drug among celebrities and people in the weight loss industry, which has only been reinforced by the success of it so far. And then this kind of cultural boom regarding the medication, all the economic implications, has been this vicious cycle where we see more and more media about Ozempic, more and more news about it, and then more and more people using it, which has unfortunately led to shortages as well as further driving profits and creating more incentives for companies to further develop it.
With that being said, we wanted to take some time to go through the evidence-based indications for semaglutide. And to do that, we're going to start with the trials focusing on type 2 diabetes. And these are largely the SUSTAIN trials. So the first SUSTAIN trial came out in 2017. And this was looking at patients who had type 2 diabetes, and then they were randomized to either semaglutide or placebo. And the patients that started this trial, they had type 2 diabetes, but they had only been treated with diet and exercise prior to this. Most of the patients entering the study had a hemoglobin A1C of around 8%. That was the average. And as you can see here, with the addition of semaglutide at a dose of 0.5 milligrams or the higher 1 milligram dose that's used for diabetes, there was a significant reduction in the hemoglobin A1C, notably about 1.4% with the lower dose and 1.5% with the higher dose. Whereas with the placebo, as you can expect, there was very minimal decrease in the hemoglobin A1C. What was also noted in this trial was a significant effect on weight, as we've mentioned. And so patients who were in the semaglutide groups were losing between 3 and almost 5 kilograms of weight, as opposed to just around 1 kilogram in the placebo group. In this trial, there was no difference in side effects between the two groups and no noted difference in discontinuation of the study drugs. Moving on to the SUSTAIN 2 trial, this also came out in 2017 and was looking at patients who had type 2 diabetes. However, these were patients who were on metformin or aglitazone, and then they were being randomized to either receive semaglutide or sitagliptin as add-on therapy to that. Once again, looking at the change in hemoglobin A1C and looking at the change in weight. And so again, patients were starting with a hemoglobin A1C of around 8% in this trial. And when they were randomized to the semaglutide group, there was a significant reduction between 1.3 and 1.6% in their hemoglobin A1C, depending on the dose. Whereas with the sitagliptin, there was a reduction in just around 0.5% in the hemoglobin A1C. Once again, there was a significant reduction in weight, as you can see with the semaglutide, whereas with sitagliptin, there was still some weight loss, but not as much as with the semaglutide. In this trial, though, we started to see some of the GI-related side effects, and notably between 8 and 10% of patients in the semaglutide groups discontinued the drug due to side effects, and this was largely driven by GI-related side effects, whereas in the sitagliptin arm, around 3% of patients discontinued the drugs. Moving on to SUSTAIN-4, which also came out in 2017. This was once again looking at patients with type 2 diabetes who were already on metformin plus minus a sulfonylurea, and they were randomized to either receive semaglutide or basal insulin, so insulin glargine. Once again, looking at the hemoglobin A1C, there was a significant reduction in the hemoglobin A1C with the semaglutide, between 1.2% with the lower dose and 1.6% reduction with the higher dose of semaglutide. There was a reduction in the hemoglobin A1C as well with the insulin glargine, but with semaglutide, there was actually a greater decrease in the hemoglobin A1C. Additionally, one of the things that really made semaglutide attractive in this study was the fact that when patients start insulin, sometimes one of the things that they can be concerned about is some weight gain. And in this trial, it was shown that patients who were randomized to the insulin glargine arm of the trial did have around a 1 kilogram weight gain, whereas as we've come to expect, the patients in the semaglutide arm had quite a significant weight loss, with around 3.5 kilograms lost with the lower dose of semaglutide and around 5 kilogram weight loss over the course of the trial with the higher dose of semaglutide. Once again, there was a significant amount of side effects in the semaglutide arm. Around 15% of patients did stop semaglutide due to GI-related side effects, whereas about half this number, around 7% of patients in the insulin glargine arm discontinued the drug secondary to side effects. And in that case, the side effect tended to be more along the hypoglycemia route than along the GI side effect route. Moving on to SUSTAIN-5, this took place in 2018, and it was looking at patients who, once again, had type 2 diabetes. But in this case, the patients were already on basal insulin injection plus minus metformin, and they had to have at least a hemoglobin A1C of greater than 8% to be enrolled in the trial. So they were randomized to receive semaglutide as an add-on therapy to their metformin and basal insulin, or to receive placebo. And in this case, there was once again a significant decrease in the hemoglobin A1C with the semaglutide, and as expected with placebo, there was a very minimal decrease in the hemoglobin A1C. Additionally, there was once again this weight loss that we are seeing with semaglutide that was much more significant than with the placebo arm of the study. And the main reason that this trial was conducted was with the addition of semaglutide onto patients who were already on basal insulin, there was a concern that there might be a risk for hypoglycemia. And so the risk ratio for hypoglycemia in this trial was around 2.4. And the study designers actually noted that this was a positive because with patients going on to semaglutide, they might be able to back off on the dose of insulin that they require. And so then they would be less at risk of some of those insulin-related side effects, such as some of the weight gain that patients are trying to avoid. With this being said, if patients are already on insulin and they're being started on semaglutide, it is important to counsel them around monitoring their sugars and to have follow-up with them to make sure that their sugars are within target and they're not experiencing hypoglycemic events, and that they're appropriately titrating their insulin as they're adding semaglutide onto their therapy. Moving on to SUSTAIN-6, this came out in 2016, and this was looking at more of the cardiovascular effects associated in patients with diabetes. So to be in this study, patients once again had to have type 2 diabetes. They could be on any oral anti-hyperglycemic regimen, any insulin regimen, but they had to have at least a hemoglobin A1C of 7%, and they also had to have either established cardiovascular disease, chronic kidney disease, congestive heart failure, or at least one risk factor for coronary disease. And in this trial, the primary outcome was a composite outcome of cardiovascular death, non-fatal MI, and non-fatal stroke. And patients were randomized to receive either semaglutide or placebo. And as you can see in this primary outcome, those that were on semaglutide had a significant reduction in the primary outcome. But if you break this up into the component parts of that outcome, you can see that this was largely driven by the fact that there was a reduction in non-fatal stroke with the addition of semaglutide. There was also a trend towards a decrease in non-fatal myocardial infarction, but this was not significant in the trial, and there was no significant difference in death from cardiovascular causes. So although we see a decrease in the primary outcome, which is a composite in this case, this is largely driven by the fact that there was a decrease in non-fatal stroke with semaglutide. The number needed to treat in this trial was calculated as 45 for the primary outcome. Those are all the studies that we wanted to give you an overview of with regards to type 2 diabetes and the indications for semaglutide. But the other main indication for semaglutide is often related to weight control. And so we'd like to go through some of those trials with you as well.
So given the noticeable weight loss that we saw in the type 2 diabetes population, the STEP trials set out to estimate the efficacy of semaglutide in reducing weight in the non-diabetic population, people with overweight and weight-related comorbidities or obesity, given its low risk to cause hypoglycemia outside the setting of co-administration with an insulin secretagogue. And the STEP 1 trial was conducted in 2021. And it looked at people with either a BMI 27 and above and a weight-related comorbidity, which does not include type 2 diabetes. So things like hypertension, obstructive sleep apnea, metabolic-associated fatty liver disease. Sorry, can you go upward? Yeah. And in this STEP 1 trial, semaglutide 2.4 milligrams subcutaneously weekly was compared with placebo, in addition to lifestyle interventions in both treatment arms, which included a 500-calorie deficit and exercise of 150 minutes of physical activity weekly. And as you can see, there's a remarkable loss of roughly 14.9% from the baseline body weight at 68 weeks compared to 2.4% with placebo, with an estimated treatment difference of 12.4%. And that roughly equated to 15.3 kilograms in the study. Interestingly, in terms of exploratory endpoints, while these participants did not have diabetes, a number of them did have prediabetes, and it was found that 84% of the participants taking semaglutide actually had resolution of prediabetes at the end of the trial, compared with to only 47.8% in the placebo group. There were similar rates of overall adverse events, but the GI adverse effects were more common with semaglutide. This is a theme that will be common amongst the upcoming trials that I will be discussing. These GI side effects are usually mild to moderate in nature and transient, and they are most noticeable during dose escalation periods, and often do not result in treatment discontinuation. There were no significant differences in acute kidney injury or hypoglycemia between both treatment arms in the study. The STEP 2 trial looked at weight loss specifically in the type 2 diabetes population, with participants having an A1C of 7 to 10%. These participants were allowed to be on oral agents as long as they had started them at least 3 months prior to screening. And semaglutide here was compared to placebo. Again, semaglutide was given at a dose of 2.4 milligrams subcutaneously weekly and 1 milligram. All treatment arms were also on a calorie deficit diet and were assigned to physical activity. And we see a 9.6% body weight percentage change from baseline with a 2.4 milligrams and 7% with a 1 milligram. And the participants on semaglutide were more likely to achieve a weight loss of at least 5%, which most clinical guidelines recommend as an initial starting point to see benefits in terms of weight-related complications. And interestingly, the A1C difference between the 1 milligram and the 2.4 milligrams in terms of A1C lowering, we don't see that big of a difference, but we do see increased weight loss. The STEP 3 trials is very similar to the STEP 1 trial in assessing semaglutide versus placebo for weight loss, but in this study, they tried a more intensive diet and physical exercise regimen. We still see similar numbers of weight loss, change in mean baseline weight of 16%. So really my takeaway from the study is the physical activity and diet are important, but the degree of restrictions might not to be as heavy as they were in this study. And the STEP 1 could have had a more adherent regimen. In the STEP 4 trial, what's interesting about this study is they looked at what happens when semaglutide is discontinued. And I think that this is something that all of the patients have been asking. I think prescribers are asking, is this weight loss temporary? what are the side effects of stopping it. And 20 weeks into 20 weeks after a semaglutide run-in, participants were randomized in a 2-to-1 fashion to either continue semaglutide or be switched to placebo. And as you can see, those who continued semaglutide continued to demonstrate ongoing weight loss, and this kind of plateaus at 60 to 68 weeks, which is not different from the previous studies, but those switched to placebo started to regain weight, unfortunately. The STEP trial was designed in a larger scale to look at the effects of semaglutide in a more longer time frame. And step 5, the people that were started on semaglutide were followed for 2 years. As we can see here, after the 60 to 68 weeks plateau, you don't see any ongoing weight loss. And I think another interesting thing about withdrawal of semaglutide, if we look at the step 4 trial where they withdrew after 20 weeks, I think you could wonder, what if we had continued for a longer period of time and then discontinued? Could there have been some kind of change or some kind of metabolic reset that happens after a certain period of time, after which if we had withdrawn semaglutide, the effects would be more withstanding and more permanent? And so the step 1 extension looked at what happened after 68 weeks. The individuals that were on the semaglutide that came off of it, what happened to their weight, what happened to their prediabetes. And a large number of these individuals regained weight. The people who had resolution of prediabetes, we saw that they started to redevelop prediabetes. At the 120-week mark, we can see that they're still at the minus 5% compared to where they were in terms of their body weight at the start of the study. But this, I think, just further consolidates that semaglutide is more likely to be a long-term treatment, and obesity is more of a chronic condition. There's no quick fix, unfortunately.
So with that, we wanted to summarize the indications that there currently are for semaglutide, and the current guidelines recommend semaglutide in 2 major conditions, type 2 diabetes and obesity management. So in summary, the indications for type 2 diabetes, the use of semaglutide tends to be as an adjunctive therapy when lifestyle changes or metformin are not sufficient or not an option. There is some discussion that semaglutide might start to move into the place where it's potentially a monotherapy for type 2 diabetes, but this is not yet reflected in the guidelines. And people are recommending that, particularly if a patient has type 2 diabetes and any cardiac risk factors, obesity, or a high hemoglobin A1C, that semaglutide be considered as a treatment option for them. With regards to obesity, current guidelines recommend semaglutide when BMI is greater than 30 or BMI is greater than 27 with a weight-related comorbidity, whether that be type 2 diabetes, hypertension, dyslipidemia, OSA, or metabolic-associated fatty liver disease. So very similar to other recommendations for weight-related management. And this is particularly if patients have not met their weight loss goals, which is a loss of at least 5% of total body weight at 3 to 6 months with comprehensive lifestyle interventions alone. Additionally, I think it's very important to talk about some of the adverse effects of semaglutide, and notably the one that we hear about most commonly is the GI distress. And as we mentioned, it tends to be associated with the titration up of semaglutide, but it is something that patients have had significant struggles with in some cases. And this can be a case of abdominal pain, nausea, vomiting, diarrhea, or constipation. And there is some reports that there's also been AKI associated with this, and often from a mechanism of a pre-renal standpoint, secondary to the GI distress. Additionally, some of the other side effects to be aware of would be an increased incidence of retinopathy with starting semaglutide. And the mechanism behind this is thought to be due to the rapid improvement in hyperglycemia, which causes some worsening of the retinopathy. So if patients have very advanced retinopathy, secondary to their diabetes, it's often a good idea to hold off on starting semaglutide until you have a little bit better control to avoid worsening that retinopathy. Additionally, as with other therapies or bariatric surgery that causes rapid weight loss, there is a risk of gallbladder pathology such as cholelithiasis, secondary to that rapid weight loss. And then the other 2 major side effects that the FDA warns about are pancreatitis. And with that, the FDA actually recommends that if pancreatitis occurs and is thought to be secondary to semaglutide, that patients permanently discontinue semaglutide and do not retrial it after the pancreatitis. And additionally, the risk of medullary thyroid cancer, which there is a black box warning for. with regards to semaglutide. And so the current recommendation is that if patients have a history of medullary thyroid cancer or any family history of a multiple endocrine neoplasia syndrome, that they do not take semaglutide. Additionally, semaglutide is not recommended in pregnancy, and because it has that long half-life, it's actually recommended that if an individual is thinking about becoming pregnant, they're stopping their semaglutide at least 2 months before their planned pregnancy. And like with a lot of other medications, there is a lack of data surrounding breastfeeding around the use of semaglutide, but it is thought that it is likely safe while breastfeeding. But once again, we do have a lack of this data.
We did want to highlight a bit more about the GI side effects because it is the thing that patients will often ask about and should be counseled on before starting Ozempic. A lot of the mechanism of these incretins is that they slow gastric emptying. And as a result of that, patients who are used to eating more will not be able to tolerate that amount of food and will have very severe GI side effects as a result of this, in addition to loss of appetite, loss of craving for food. So for patients that value food a lot, this might not be an appropriate treatment because this is something that's going to prevent them from eating a lot. And it is important that people might see very, very significant side effects. There's been a number of patient testimonials, one of which we've highlighted here, about how distressing these side effects can be. So it is important for patients to be aware that when they're starting these medications, especially at higher doses, this may be something that they experience and it might not be the right choice for everyone. There's also currently a class action lawsuit being launched against Novartis as a result of gastroparesis when taking the medication. This isn't necessarily super surprising given, as I mentioned, the mechanism of these incretins is to slow gastric emptying, but importantly in the list of side effects that the drugs released, while they did mention GI side effects, they didn't specifically mention gastroparesis as a potential. And as a result of that kind of oversight, unfortunately, there is a class action lawsuit being launched against the company as we speak. I think it was filed in August. So we've talked a lot about the pre-existing indications for Ozempic, the current evidence base, and some of the guidelines, but we also wanted to go in some of the future directions of Ozempic and what's next for these medications. So interestingly, there was very recently a very small, less than 20 patients trial in type 1 diabetes and Ozempic in early type 1 diabetes. So they gave these patients semaglutide, and they found that some patients were able to come off of insulin entirely. All patients were able to decrease doses of insulin, and biochemical markers of diabetes severity, including C-peptide and A1C, dropped in all participants. So even in patients with type 1 diabetes, this is a potential for therapy that is being explored currently. Other trials that have been recent, the STEP heart failure trial. So this looked at patients with obesity and heart failure with preserved ejection fraction, which has been historically an extremely difficult disease to treat symptomatically. And we saw, obviously, as you'd expect, that with semaglutide, there were significant decreases in weight, but we also saw significant increases in Kansas City questionnaire of quality of life with heart failure. So heart failure symptoms, including dyspnea, peripheral edema, hospitalizations, and we saw all of these improve with semaglutide. So it's currently being thought of as a promising therapy in heart failure with preserved ejection fraction as well. Other trials have included the SELECT trial, which is currently forthcoming. So this trial will be presented at a conference later this year, but they did importantly release kind of their preliminary results beforehand. So the SELECT trial was looking at, based on the kind of current evidence that shows semaglutide does have significant coronary benefits and benefits with MACE. So they looked at non-diabetics with obesity and coronary disease. And the preliminary reductions in this obviously high-risk population did show a 20% reduction in major adverse cardiac events with semaglutide. So very encouraging results. And this is already kind of being reflected a little bit in the guidelines. The current chronic coronary disease guidelines are already recommending that in many of these patients with diabetes, considering addition of a GLP-1 agonist. And I think that these indications are only going to expand with these kind of future trials looking at these medications, even in non-diabetics. There's also, as we mentioned earlier, with the popularity of these medications, with the huge demand for the weight loss, but also the reductions in A1C and their metabolic benefits, there's all these add-on kind of medications being marketed. So in addition to semaglutide, which is only a GLP-1 agonist, we're seeing dual receptor agonists, a GIP and GLP-1 receptor co-agonist, so tirzepatide, in the SURMOUNT-1 trial, which showed both more significant reductions in weight loss and more significant reductions in hemoglobin A1C with these medications and with semaglutide. And even more recently this year, there actually was a triple hormone receptor agonist, retatrutide, which looks at GLP-1, GIP, and glucagon, interestingly, as a co-agonist. And if you remember the STEP trial, we were seeing up to 15% weight loss at 68 weeks in this triple hormone receptor agonist, we're seeing up to 25% weight loss at 48 weeks. So huge benefits in these medications and quite dramatic results early on. So I think that these medications are only going to expand further. We're seeing a lot of interest in both new indications, but also even more potent formulations of these kind of medications. There's too many trials ongoing to list, but just a few of the other areas that are being looked at. Oral GLP-1 agonists are not currently available in Canada, but they are available in other countries and likely will be soon available in Canada. There's currently research going on into using these medications for addictions and craving. Interestingly, there was a small study in rats that showed that they were decreasing their alcohol intake. I'm not sure how you measure that in rats, but with GLP-1 agonists, and many kind of patients have been reporting decreased craving for smoking and vaping while on Ozempic. So this is an area of investigation right now as well. With metabolic associated fatty liver disease, there's currently trials investigating GLP-1 agonists in this indication as well as in PCOS. So there's a huge amount of kind of exploratory research in these medications. And it's very much a growing field of science, which likely will further reinforce the societal and profit-based motivations for developing these medications. So obviously, we've talked a lot about the benefits of these medications, but I do think it's important that we look at how we're talking to patients with obesity, especially given that there's known to be a huge role of fat phobia in medicine. And I think that especially when we're looking at potent medications for weight loss, we need to be really cautious of our own internal biases. This is from the Joint International Consensus Statement for Ending the Stigma of Obesity, but it's essentially reinforcing the fact that people who are overweight and obese are not only facing significant stigma in society, but also in healthcare as well. And unfortunately, this is actually reflected in the fact that they're getting worse care. This is a list of kind of evidence grades for various kind of statements about obesity. But to summarize it, patients who are obese are often facing huge stigma in healthcare environments. They're feeling not empathized with by healthcare providers. So that objective scales of healthcare empathy are lower in patients with obesity. Healthcare appointment times are lower in patients with obesity. Healthcare outcomes, specifically in certain cancers, tend to be worse in patients with obesity, independent of kind of underlying physiologic correlations with these things. And importantly, even in addition to this, there's actually been evidence that shows that weight discrimination, independent of physiologic risk factors, has been increased with increased markers of stress and increased mortality in these patients. So this is not a benign thing. This kind of stigma that healthcare providers have towards people who are overweight is significantly impacting not only people's mental health and quality of life, but also their healthcare outcomes. And this leads to delayed diagnoses in patients who are overweight, things being attributed to weight, behaviors that are tantamount to eating disorders, which are more prevalent in people who are overweight and often more severe, being reinforced by healthcare providers. And so we really need to be cautious that when we talk about these medications, we're not indicating that it's a lifestyle choice at all, but also being sure that we're aware of our own biases and when we go into these conversations. This is the Canadian statement on reducing weight bias in obesity management practice and policy. The recommendations here are summarized. But I think it's important to know that these resources do exist and that this is an issue. Finally, when we're looking at kind of fat phobia in medicine, it's important to note that there are a difference between cardiometabolic health and weight. So we use BMI as kind of a very crude marker of obesity. This is from the Cardio-1 trial, which followed over 14,000 patients for a number of years, and basically showed that even in different weight groups, there's a number of different cardiometabolic phenotypes with regards to things like hemoglobin A1C, blood pressure, and metabolic risk factors. And it's important not to collate weight with kind of metabolic health and look at other markers, and not just looking at BMI, but looking at people's lifestyle habits, people's exercise, people's diets, and their underlying cardiometabolic risk profile, so that we're giving everyone optimal care and not just collating weight as a marker of unhealthiness. So where does this leave us with medications like Ozempic that have been shown to treat obesity as well as other things like type 1 diabetes? I think that we've established in this presentation that there's a number of very compelling indications for Ozempic in type 1 diabetes, in obesity, and these medications have shown very significant reductions in significant markers of health like diabetes, like coronary disease, like non-fatal stroke. And then many of these benefits are probably because of weight loss. But at the same time, we have to be very conscious of the biases we go into these conversations with, and not just say that these medications are going to help you lose weight and that's why you're going to be healthier, but focus on the fact that they're actually helping to address the underlying cardiometabolic causes of weight and counseling patients appropriately that weight loss is not the only solution to their problems, and that they can't just chalk up all the benefits of these medications to weight, that lifestyle interventions like diet, exercise are still crucially important independent of weight loss. And so we can't just use these medications as a quick fix, especially as we've mentioned, the fact that their benefits are likely not longstanding if the medications are discontinued. And so this is one more tool in our arsenal, but we can't just say weight loss and the medications causing weight loss is simply a panacea treatment we can offer to everyone. So going back to the case, Deborah was started on Ozempic after a thorough discussion with her family doctor about the potential risks and benefits of these medications, as well as their side effects. She was titrated up to a dose of 2 milligrams subcutaneously weekly and achieved a 16-kilogram weight loss after only 8 months. However, after further discussion, she mentions that she's been severely restricting her caloric intake and has been consuming 850 kilocalories a day of food only and denies any purging behaviors. Her most recent A1C, however, is 5.6%, showing that she has successfully treated diabetes, and her family doctor is unsure of how to proceed. So that's kind of what we wanted to leave you guys with. We would welcome any discussion at this point, and we're curious what your thoughts are. Thank you so much for your time and for listening. And these are the take-home points of the presentation. So semaglutide is emerging as a first-line treatment for diabetes or coronary artery disease and obesity, even potentially independently of diabetes. There are significant side effects associated with semaglutide, which are often incompletely discussed with patients. And given the huge success of these medications, there's a lot of societal pressure, both in the media and in the pharmacologic industry from a profit perspective. And so we need to be mindful of these external pressures as well as our own intrinsic biases against overweight bodies when we're discussing these medications with patients, and be mindful of their effects on patients. Thank you so much. And we'd like to thank our supervisor, Dr. Sofrin, as well.
That's excellent. Thank you so much for a comprehensive and very thoughtful look at what's a very topical medication. You can't walk through a subway tunnel or drive past any sort of billboards without seeing advertisements for Ozempic. So, really interesting look at the evidence behind its use. Thanks to all of you and to Dr. Sofrin for supporting your presentation. We've got 2 hands up. So we'll start with Dr. Curnew, who has a question. Go ahead, Dr. Curnew.
Thank you so much. Really enjoyed the presentation. Can everybody hear me?
We can.
Perfect. So Ozempic has been a godsend for many patients, but the issue about cost, I just wanted to explore that a little bit more. So if you use 1 milligram a week, it costs about $250 per patient. And yes, you get extra benefit from weight reduction going to 2.4 milligrams. So that would be over $500 a month. And in most of our practices, 70% of patients are overweight. So we're talking about millions of dollars per physician if we use it the way you express that, and that's not something to be concerned with. I'm just trying to figure out is that there's also issue about fat loss versus muscle mass loss, and I'm wondering if you have any thoughts about that, because in some trials, a third of the weight loss is muscle mass. And so, where we talk about resistance training being important, adequate protein in the diet, and from a societal issue is that most patients want to stop, and I realize that there's a pressure not to because of the weight reduction. So, and I'm finding that some people are very responsive to low-dose Ozempic, so you can use 0.25 milligrams every week and use the 4 milligram cost, and that becomes $250 for 4 months. So the range can be from $250 for 4 months to some patients to $500 a month. So I think we have to be cautious how we're spending money. And there are times of stress and intermittent use of it. And so I've been exploring that a little bit more. So I'd be curious to see how people want to factor that, intermittent using medications during different events, changing behavior, and the issue about fat loss versus muscle mass, and how we make sure, because some people will lose more fat versus muscle mass, and how we really encourage people to really pay attention to that. So appreciate your comments on all those areas. Great presentation.
Thank you so much for your question. I think in response to the cost, it is a very expensive drug. And it would be very interesting to see if any future kind of studies can look at what are the potential costs incurred by prescribing Ozempic, and then what are the costs that are avoided by improving the cardiometabolic health of the individuals on Ozempic by reducing weight, reducing prediabetes, potentially pushing type 2 diabetes in remission. Are we actually going to be saving and cutting costs in other aspects of healthcare? So that would be interesting to see. But it is, pretty expensive, especially at the higher doses. I agree with you, which is a bit of an obstacle. And to address the second issue, which is how much weight loss is lean body mass and how much is fat mass. If you look at the step 1 study, a sub portion of these individuals, particularly the ones with higher BMIs of 40 and above, actually underwent DEXA scans, which is one of the most sensitive studies that actually look at fat and body compositions. Interestingly, I think we're all used to seeing DEXA scans for bone, but it actually has very good assessment and estimation of body fat percentages. So, I'd have to know where the department services for maintenance of the code red systems in the main building and the parking ramp. If you have a code red, please call extension 5555. Sorry about that. So these individuals, I think there were around 100 participants, and then they compared these metrics after the 68 weeks of Ozempic. And unsurprisingly, they had loss of both fat as well as lean body mass. And however, it was more fat that was lost than lean body mass. It's still a bit disheartening. We would hope that most of this loss is fat loss, and then this lean body mass could help increase their baseline metabolic rate and essentially could promote health. So I think it would be interesting to see if future studies could incorporate more resistance training and cater the physical activity portion of these lifestyle interventions to maintain or preserve muscle mass, while and then hopefully the Ozempic would target more fat loss as opposed to muscle.
Excellent. Thank you so much. We'll move on to another person who has their hand up, Dr. Ann Holbrook, who has a question.
Right. And just a short comment and a question just on the last discussion. I apologize, it's saying internet unstable here, but so the way to look at cost is around cost effectiveness. What's the value for money? As I remind everyone, this is very easy to sort out in Canada. We have an agency called the Canadian Agency for Drugs and Technology and Health. They have a huge amount of information on semaglutide. So just the short of it is, so this is looking downstream, what is the benefit on health that you gain for the cost that you pay? Ozempic came to them at $2,500 a year for 2.4 milligrams. Wegovy came at $4,700 per year for 2.4 milligrams. Wegovy targeting obesity in general, Ozempic targeting diabetes. And the summary was that neither was cost effective, did not meet the usual thresholds that we use for putting drugs on the formulary. Ozempic was close and could reduce the cost to become cost effective, which is what they did. But the reduction for obesity, even counting sleep apnea, eventual outcomes, etc., a reduction of cost of 71% was required to make it cost effective. And I don't think that amount has happened. But of course, this is a field day for generic companies who will come in cheaper. There's a huge amount of concern around budget impact, as you might imagine with these drugs. So they're very effective, but not yet cost effective in conventional terms. My question had to do with what do we know about semaglutide, which looks to be a very effective drug, but it's like a lot of medications we have. They're meant to be built on a background. And here the background is lifestyle. And, you know, these patients are coming to us because they've not been as successful as they would like with our lifestyle. What do we know from the trials, or do we know anything on how well the semaglutide itself helped people manage their lifestyle? For example, if you're very overweight, lose some weight, you may actually be able to then be more successful with an exercise regimen, something like that. Any thoughts there?
In the trials that we looked at, especially the STEP trials, which were looking at more the obesity side of things. The trials looking at diabetes didn't have as much in terms of an actual weight regimen or like a diet or exercise thing. But in terms of looking at the trials for obesity, they did vary a little bit, as we spoke about, in terms of the actual restrictiveness of the diets that were involved and the actual exercise. But I think overall, the main point that came out of them was, like you mentioned, Dr. Holbrook, that if patients are able to have some weight loss with the semaglutide, they might then be able to engage more in exercise or more with dietary changes. But the current indication for starting semaglutide is that they do have to have had unsuccess with comprehensive lifestyle management, which would be mainly the diet and exercise before they're starting semaglutide. And this would largely be due to the fact that I think, especially with the popularity that we mentioned and the amount of celebrities on it, we're very cautious that we don't want semaglutide to just be something that we're handing out like candy to try to have weight loss effects.
I would also just say that with some of the craving research that's going on right now, that might be useful in looking at comorbidities as well. So if people are able to stop smoking with semaglutide, is that going to be a permanent effect, and will that kind of help with metabolic risk factors down the line? So I think that would be interesting to see in the future years. And then just going off of the cost statement briefly as well, it's interesting the comparisons between Canada and the US. In the most recent, I think the AHA rather, chronic coronary disease guidelines, they actually have a like cost statement in all of their recommendations, and they actually were projecting a high cost value for like high value rather of GLP-1 agonists in patients with obesity and coronary artery disease, suggesting that would actually be very effective in reducing long-term healthcare costs. And I'm not sure if that just reflects the American versus Canadian system, but it's interesting to see the kind of different perspectives on that in different guidelines.
It's not so much the different guidelines, well, it is partly, but it's the populations and what the cost is of that population for that disease. So I guess what I'm asking is probably something that would be addressed more by meta-regression, which would be looking at all the trials and seeing how successful the patient had been with underlying lifestyle as well as their semaglutide on the outcomes. That would be an interesting study.
Thanks very much, Dr. Holbrook, and thanks to our panelists for that question. I'm going to hand things over to Dr. Nguyen to cover some more of the Q&A.
Okay, so looking at the Q&A, I have 3 questions from Dr. Khurram Khan. The first one is in regards to GI side effects. Were they measured in specifically regards to gastroparesis? And then the second part of that question is, did it reverse after Ozempic was discontinued?
To answer the first piece, did they measure specifically as gastroparesis? No. It is kind of very implied in the sense of like this is most likely the underlying pathophysiology, but if you look at the tables, it will specifically mention nausea, vomiting, constipation, etc., and go into each individual symptom alone, and then ask for resolution.
I think they did resolve with cessation of the medication, yeah. As like a lot of the benefits, like the weight loss and the A1C reductions resolve with cessation of medication, the side effects also tend to resolve, which is encouraging. Although I'm not sure specifically with gastroparesis. We'll have to look at this lawsuit for more details about that.
I think also given the long half-life of semaglutide, it does take some time sometimes for the resolution to occur.
Thank you. So the second question is, are benefits in heart disease noted from any specific known pathway or only presumed from the weight loss? Is it used in kids for obesity?
As far as the STEP trials so far, they've all been on adults 18 years and above. However, I believe there is a STEP teens coming out. I'm just not sure of the age population, but the teens would suggest teenagers, but I'm not aware of any current large body of evidence supporting it.
And with regards to the kind of cardiac events, all the trials so far, we haven't done any in kind of non-obese patients, so it'd be difficult to kind of tease apart the association between kind of weight loss versus just other effects on coronary disease, but that is kind of the current presumed mechanism both for coronary disease and other adverse cardiac events, yeah.
Great. And then one more question from Dr. Khan before I actually have a question myself. So were there any nutritional deficiencies measured in these patients?
Particularly, at least the STEP trials, they did not specifically look. They measured other things. They measured lipid profile, CRP, all sorts of fancy things, but they didn't look at iron stores, for example, or B12, B1.
Thank you. And then I have a question as well. You guys were going over the indications for Ozempic, including BMI targets. And I was wondering if there were any kind of considerations of different like ethnicities and BMI cutoffs, because there are different effects in terms of like, you know, the kind of cardiovascular effects in certain kind of ethnic groups.
You're absolutely right. There are different BMI targets, especially for Asian populations. And then there are some new STEP trials actually addressing the Southeast Asian population to address this better. But yeah, there are differences, and the guidelines for obesity at least place emphasis in taking that into consideration when treating your patient, taking their race and their BMI according to that race into consideration.
All right. Thank you very much, guys.
Thanks. And it looks like there's one more question that there are a number of comments and information in the chat. So I encourage attendees to have a look there, including some links. One last question that I see also from Dr. Greg Curnew. Actually, it's a two-parter. When should we stop the drug after failure of weight reduction? If patients do not lose 5% of weight, do we stop the drug, or are we happy with no additional weight gain? And then the second part of what percentage of patients were dropouts, and was there a failure to complete? What are the numbers and how are they counted in the results?
Yeah, so the dropout rates in a lot of these trials, it depended on the specific trial, but they tended to be around 8 to 10% for most of these, depending on side effects. And with regards to cessation of the medication, I believe the current recommendation is that 3 months without any kind of metabolic or weight loss targets. That's when you can discontinue the medication. But it's worth assuming patients can tolerate it going for that long, at least to monitor for benefits.
Excellent. Thanks so much. I think that answers those questions nicely. You guys had a lot of questions, and you really showed your expertise that you've developed on this topic. So thank you. And thanks to everyone who attended today. Thank you to Dr. Huynh for co-hosting with me. As we wrap things up, I'll just remind you that rounds are back next week. HHS is the host, and we'll have Dr. Ronald Ramos as part of our new recruit series, who is one of our new neurologists. After that, October 5th will be respirology with Dr. Boushahri, and following that on October 12th, we'll have an IPAC feature with Dr. Sarah Khan. Thanks again to everyone. Wish you all a fantastic day and take care.